Hope you had time to scan in the QR code, and if not, you feel free to text us. Thank you, Dr. Shujaat, for being with us today.
Thank you. Yeah. For the opportunity to give a talk. Good afternoon to everybody. Can you all hear me well, I hope?
We can, and we can also see your slides perfectly.
Good. Whatever. Okay. Yeah. So I shall start.
Take the mouse and
The mouse and
yeah, click
this
on
one.
that.
Okay, I thought.
You can do it like that, or even if you. Sorry.
There we go. Okay. So we'll try to do this as interactive as possible. Unfortunately, being virtual may not allow for that much interaction. Case one is of a 50-year-old woman who presents with sudden onset right pleuritic pain and teaspoonful hemoptysis, 2 weeks status post modified radical mastectomy for breast cancer. Heart rate is 120 beats per minute, blood pressure is 120/80, room air oxygen saturation is 95%, chest is clear to auscultation bilaterally with a loud S1, and lower extremity is swollen. Chest X-ray shows a small right pleural effusion and segmental consolidation in the right lower lobe base. EKG shows sinus tachycardia. So when faced with a case like this, what is the most probable diagnosis? A, pulmonary embolism, B, pneumonia, C, malignant pleural effusion, or D, PTMA, which stands for mouthful, pulmonary tumor microangiopathy. So let's see, where do we see the responses? On chat or unmuted verbal shouts?
If you guys want to shout out your responses in the chat, we're seeing that the majority of people are saying A, pulmonary embolism.
Excellent, that's good. So there's enough here for all of this to be possible. A pleural effusion in a patient with cancer, there's always the possibility of malignant effusion. Consolidation on a chest X-ray always brings up the possibility of pneumonia. And tumor emboli that block branches of the pulmonary artery, and if enough of them are blocked, can cause a rare condition. Pulmonary tumor microangiopathy is also another possibility. But none of this would present with a sudden onset of pleuritic pain as well as a swollen lower leg. So pulmonary embolism would be the correct diagnosis. When we use the term pulmonary embolism, we almost always assume it's thromboembolism, but there can be other kinds of emboli. It could be fat, air, amniotic fluid, septic, or like I mentioned earlier, tumor. So the talk will focus on pulmonary thromboembolism and not the other kind of emboli. Now let's talk about another case. This one's of a 55-year-old man who presents with sudden onset shortness of breath, 4 days following a sprained ankle that immobilized him. His heart rate's 120 beats per minute, blood pressure's 120/80, room air oxygen saturation is 92%. Chest to auscultation bilaterally with a loud S1. Chest X-ray is normal and EKG shows only sinus tachycardia. What is the next step in this case? A, determine clinical probability of pulmonary embolism. B, blood D-dimer. C, do a CT pulmonary angiogram. D, ultrasound exam of legs. So that's what the response to this one is.
Again, guys, you can put your response or type your response in the chat. I'm gonna wait for a second. The majority of people are saying option A.
I'm pleased to hear that you would want to first determine clinical probability of pulmonary embolism. Unfortunately, it's not what's really done in practice. And a lot of times you will see CT pulmonary angiogram being done right away without any thought being given to an objective determination of the probability of pulmonary embolism. And a lot of times that is beyond our control because such patients present to the emergency room where such evaluation takes place. And nevertheless, we want to look at how would you make a diagnosis of pulmonary embolism. It depends on clinical probability of pulmonary embolism and diagnostic testing. Probability will depend on presentation of the patient. Does it fit into one of the different ways in which a patient with a pulmonary embolism presents? And do they or do they not have any risk factors for PE? Diagnostic testing includes a number of options that are D-dimer, CT pulmonary angiogram, VQ scan, which is nuclear ventilation perfusion scan of the lungs, ultrasound exam of the leg veins, and echocardiography, which includes both transthoracic and transesophageal, and pulmonary angiogram. So clinical probability depends on the presentation and risk factors. And presentations of a patient who has acute PE are of four kinds. Most commonly, pleuritic pain or hemoptysis or both. On examination, there may be crackles in the area of the lung affected by a pulmonary infarction that causes the pain. EKG and AKG are usually normal, whereas the chest X-ray shows an opacity or atelectasis, and there may be an effusion in response to the area of pulmonary infarction. Second most common presentation is somebody who has sudden onset dyspnea, hypoxia on examination with clear lungs and a normal chest X-ray. And less common are cardiovascular collapse and asymptomatic incidental. Cardiovascular collapse would present as a medical emergency with tachycardia, hypotension, hypoxia, and EKG abnormalities, right bundle branch block, and S1Q3T3 pattern, E-wave inversions in V1 through 4 precordial leads. And this presentation is based on studies of patients who had no cardiopulmonary disease to begin with. There are some risk factors that are categorized into strong, intermediate, and weak, depending on the odds ratio, more than 10, 2 to 9, or less than 2. And you can see the ones highlighted in red are going to be the ones that have been found to be most predictive of a DVT or PE. Others are strongest include surgery, orthopedic, major general or major trauma, spinal cord injury, and an acute MI or congestive heart failure. And on the weak end are minimally invasive, laparoscopic surgery, immobility due to prolonged car or air travel, bed rest of more than 3 days, increasing age, obesity, pregnancy, and varicose veins. We have a number of those to really be at risk of PE. One by itself should not be enough. Intermediate risk factors would be arthroscopic knee surgery, central venous line in place, failure, hormone replacement therapy, malignancy, oral contraceptive therapy, paralytic stroke, where the leg is plegic and can't move and is postpartum, previous VTE, and thrombophilia, whether inherited or acquired. Knowing what the different presentations are, how chest X-ray, blood gas, EKG looks, none of that, unfortunately, is helpful by itself. Symptoms and signs are non-specific, and they may mimic a pneumonia or an eye. Chest X-ray is abnormal in the majority of patients. ABG may be normal in up to 20% of cases. And EKG signs of core pulmonale are non-specific unless they're new. And there are no risk factors in 50% of cases. So how does one go about getting a more objective idea of determining the risk of a number of clinical prediction models, Wells, Geneva, and PISA? The most validated, both outpatient and inpatient populations, is Wells. And that's what I will describe and use and advise to use. Variables that were found to be most predictive of the presence or absence of a PE are tachycardia to more than 100 beats per minute, immobilization for more than 3 days, or surgery in the last 4 weeks, previous history of DVT or PE, hemoptysis, malignancy, and lastly, alternative diagnosis is less likely. The original model scored based on the weight of the different variables, 3, 1.5, 1.5, 1.5, 1, 1, and 3 for these variables. And subsequent models made a simplified prediction by giving a score of 1 to each of these variables. In the original model, the probability was categorized as low, intermediate, or high. Less than 2 is low. Some of the variables scored 2 to 6 intermediate and score of more than 6 high. So to give a number, we would say low, intermediate, high. The probability of PE is 2%, 20%, and 50% respectively. In the simplified model, which is PE unlikely or likely, a score of 4 or less is unlikely, and a score of more than 4 is PE likely. So the difference in probability would be 5% and 40%. What are the alternative diagnoses to consider? So there have been a few studies that have looked into this, and one is from our population, which included 231 patients in a paper published in 2013. The other is a larger study from the Netherlands, which included 512 patients. So in patients who present with suspicion of PE, the diagnosis of PE is actually found in about 1/4 to 1/5 of them. The alternative diagnosis is found in more or less a similar proportion of patients. And the most common ones are pneumonia, acute exacerbation of COPD, atelectasis, acutely decompensated congestive heart failure, pleural effusion, and malignancy. Asterisks in the cross telling us that some of these may be associated with an increased D-dimer. Others you can diagnose by doing a transthoracic ultrasound and an echocardiogram. So you may not have to resort to doing a full workup for PE if alternative diagnoses are more likely. The approach will consist of whether the patient is presenting with or without hypertension or shock. In a normotensive patient, once the clinical probability of PE has been assessed and PE is unlikely or it's low or intermediate in clinical probability based on whether you use the original or the simplified Wells model, then you should take a D-dimer. And if it's negative, there's no need to treat for PE because that diagnosis for all practical purposes has been excluded. On the other hand, if the D-dimer is positive, then you have to move on to do a CT pulmonary angiogram. And if that shows no PE, then the diagnosis is excluded and there's no need to treat for PE. That's what the diagnosis is, and you treat it. On the other hand, when the clinical probability is based to be high or PE is likely, then you go on to do a CT pulmonary angiogram without needing to do a D-dimer because it will not change the probability. It will either show PE or not. If PE is confirmed, you treat it, and we'll talk about that. If there's no PE, then there's no need to treat PE, and you look into what's wrong with the patient with other testing. So here is a representative case of what filling defect looks like. The purpose of giving IV contrast dye is to opacify the blood vessels, and in the pulmonary angiogram, the focus is on making sure the timing is such that the contrast has not passed through the lungs into the left side of the circulation. So you want the pulmonary arteries to be bright, and like this serpentine filling defect across the bifurcation, a saddle PE. Or down, you can see it filling up the left lower pulmonary artery, and here it's filling up the right pulmonary artery, and you can see more of this. Here, there's a crescent of contrast flowing past this large clot in the descending left pulmonary artery. Here are some more images from the same case as we continue to go down. And then you also take a look at how the heart looks in terms of what is the size of the right ventricle compared to that of the left ventricle. Larger than the right. On the other hand, if the right ventricle becomes larger than the left, it means that clot burden is large enough to cause RV dilatation. What we don't know is how the right ventricle is contracting, because that would require a dynamic study like this. Case 3. Now that we know how to make a diagnosis of patients who are suspected of PE and have normal blood pressure, let's talk about another case. This is a 40-year-old man who was admitted with DKA. He feels faint and passes out when he gets out of bed to use the bathroom. RN attending to patient in the neighboring bed calls RRT. On arrival, his heart rate is 120 beats per minute, blood pressure is 85/55, room air sats are 92%, his chest is clear to auscultation bilaterally, there's a loud S1 and loud S2, digits are cold, EKG shows as sinus tachycardia and no STT changes. What is the next step? A, IV LR bolus, B, POCUS, C, D-dimer, D, CT pulmonary angiogram. So let's see what the responses are.
So I see the responses that are coming in slowly are mostly A, IV, LR, bolus.
Okay, good. So I see that you want to stabilize this patient, but what do we think is the diagnosis here? Do we think that this patient with DKA is still volume depleted and being bedbound and then getting up became orthostatic and fainted from that? Or being a talk on pulmonary embolism, did he throw a large clot and have massive PE causes drop in blood pressure and syncope? So if you have ultrasound, is what we usually bring to a rapid, you immediately put it on the heart and get images right away. And if the RV is dilated and the IVC is dilated, then the diagnosis would have to be in this context of somebody who has an acute massive PE. On the other hand, if the RV is normal sized and the IVC is small and shows respiratory variation, then the person is volume depleted. You don't really want to give an LR bolus to somebody who has a dilated RV because it would make the preload worse and cause RV ischemia. So the answer in this case, when you respond with a rapid to somebody like this, would be focus. And it's much quicker to do than for the LR bolus to be given. Let go on. Okay. So in the case of a patient in whom PE is suspected when it's shock or hypotension as the presentation, CT pulmonary angiogram is not something that you can do right away because the patient's not stable enough and they may arrest by the time you get them there. So you do an echocardiography. If the focus suggests that is what is the case, when RV overload is seen, then that's good enough. And then you start away treatment. If the patient is stabilized with vasoactive medicine, Levophed, for example, and you really want to confirm the diagnosis, then you can proceed to CT angiogram. Let's go back to case one. The 50-year-old woman who had right pleuritic pain and a teaspoonful hemoptysis 2 weeks following mastectomy for breast cancer. Pulmonary angiogram confirms that she has pulmonary embolism. What is the next step here? A, anticoagulation. B, venous ultrasound of the right lower extremity, which is swollen. C, transthoracic echocardiogram. Or D, all of the above.
So I see people are posting their answers on the chat, and the majority seem to think that all the above, answer D, is the correct answer.
Well, that's fantastic. I don't think I need to continue talking about pulmonary embolism. You guys know all of this stuff. Yes, that's correct. So this question looks at what you do following a diagnosis of PE, and that next step, in addition to starting treatment, is risk stratification to make sure that you know what you're going to do with where the patient goes for further management and if they need anything more than anticoagulation. So let's look at what happens when a patient presents with PE. Most of the patients do well, but some don't do well. 5 to 10% of cases present with cardiac arrest or sudden death, and it's within 1 hour and not a large window of opportunity to intervene. 5 to 10% of patients present shock. In those cases, you can help them. There are up to 50% patients with a normal blood pressure, but if you were to do an echocardiogram, they'd have right ventricular dilatation, with or without hypokinesis. And these patients are at risk of decompensation. They can go into shock, cardiac arrest, or die. So how do you identify those cases and prevent them from progressing to the state of shock is what risk stratification consists of in patients with pulmonary embolism who do not have shock or hypotension. So let's look at this algorithm for pulmonary embolism response team. At the very top, the important question to ask is, does the patient with PE have shock or hypotension? And if the answer is yes, then it is called a high risk, massive PE, and you start IV heparin bolus, followed by drip and consult critical care and activate PERT following an echocardiogram. And the patient with pulmonary embolism does not have shock or hypotension, and it's start anticoagulation, and you try to calculate their simplified pulmonary embolism severity index, PESI, simplified PESI. And on the top left corner is made of 6 variables, 3 from history, 3 from vital signs. Age more than 85, history of cardiopulmonary disease, history of malignancy, tachycardia more than 110, borderline low blood pressure, systolic blood pressure 90 to 100, and hypoxia, room-air SpO2 of less than 90%. This simplified PESI is easier to use, easier to memorize, and is as well validated as the original complex PESI. So if the simplified PESI is 0 and patient did not have syncope as part of the presentation, it is considered a low risk PE. Don't worry about activating PERT. On the other hand, if the person has a simplified PESI of more than 0, any one of these 6 variables, or they presented with syncope, it is called an intermediate risk of death or cardiovascular collapse, PE. Now, the next question then becomes is, are the vital signs abnormal? If the vital signs are what make the PE intermediate risk, meaning the heart rate's more than 110, or systolic blood pressure is borderline 90 to 100, or they're hypoxic, any one or more of these is the reason that the PE is intermediate risk, then you consult critical care and risk stratify the patient additionally with transthoracic echocardiogram and an ultrasound of the leg veins. Because if this person has RV dilatation and hypokinesis and there is a DVT, then together with the abnormal vital signs, even though it's not frank shock or hypotension, they are at the highest risk of decompensating and going into cardiac collapse. And you'd want to activate PERT because anticoagulation alone may not be enough. And want to admit them to the ICU. When the vital signs are normal and the PE is intermediate risk, then additional risk stratification may give you more time, and there may not be any evidence of elevated lactate, troponin, BN peptide, RV dysfunction, or DVT. And then it will not be an intermediate highest risk PE, and the management does not require and admission to the floor will be enough, and consulting pulmonary instead of critical care. Let's go back to case 2, that of the 55-year-old man who presented with sudden onset shortness of breath 4 days following a sprained ankle that immobilized him. Heart rate's 120 beats per minute, blood pressure is 120/80, room-air SpO2 is 92%, chest is cleared auscultation bilaterally with loud S1, chest X-ray is normal, and EKG shows sinus tachycardia. CT pulmonary angiogram confirms central pulmonary embolism, cardiac biomarkers are normal, and there is no DVT. But what is the next step in the management of this patient? A, IV thrombolysis, B, anticoagulation, C, catheter-directed thrombolysis, D, surgical embolectomy.
Okay, I can see the majority of responses go for B, anticoagulation.
Yes, you will never be wrong when the answer is anticoagulation. This patient may have been tachycardic with a normal blood pressure, which going back to this was normotensive PE, simplified PESI is more than 0, and intermediate risk PE. And because of abnormal vital signs, you did echocardiogram and cardiac biomarkers, DVT, but there's no suggestion of this being such a high risk of decompensation that you need to do more than anticoagulation. On the other hand, let's look at a patient that we discussed earlier, 40-year-old man with DKA who passed out when he got out of bed, and rapid was called. The POCUS done by rapid response team showed RV enlargement and RV hypokinesis and right lower extremity proximal DVT in the femoral vein. In this case, what is the next step? A, intravenous TPA, alteplase. B, intravenous unfractionated heparin bolus followed by drip. C, subcutaneous low molecular weight heparin in therapeutic dose. D, catheter-directed thrombolysis.
I think we're split between two answers here. It's either B or D. We're unsure. I think it's like 50-50.
Okay, so it's understandable because I'm sure that you've come across a lot of patients who are evaluated by PERT, and a lot of them undergo catheter-directed thrombolysis. So you're not seeing many patients who have been given IV thrombolytic. Remember, this patient has a blood pressure of 85/55. Catheter-directed thrombolysis takes time and is usually something you may want to use in somebody going back to who has intermediate highest risk, meaning that they're normotensive and they may be tachycardic with borderline blood pressure and RV dilatation, DVT, but they don't have hypotension or shock. Hypotension or shock, the answer based on the guidelines and what you will be asked on the boards is always going to be systemic thrombolysis with IV TPA or TNK. TPA offered here because it's the only FDA approved treatment for PE with hypotension or shock. Let's talk about pulmonary embolism when we treat it. Primary treatment of any clot should consist of reperfusion with thrombolysis, meaning there's a clot, you want to dissolve it. Secondary treatment is what anticoagulation does. It prevents more clots from forming while the body's inherent fibrinolytic system, in this case the lungs, they dissolve the clot. So anticoagulation does not dissolve the clots, but it prevents more clots from forming while the body breaks down the clot. So why is it that primary treatment, reperfusion with thrombolysis, is not the first thing that we think of unless the patient is dying? Clusters are not for everyone because there is a high rate of major and intracranial bleeding associated with such use. So here is a meta-analysis of 15 randomized controlled trials comparing thrombolysis with heparin, mortality, PE-related mortality, death or treatment escalation, PE recurrence. You can see that thrombolysis is better than heparin to some degree, but it comes at a cost. Major bleeding and fatal or intracranial hemorrhage. And this has a way higher odds ratio compared to any benefit in any of these four outcomes that thrombolysis can provide. So the risk-benefit ratio of thrombolysis does not allow primary treatment with reperfusion with thrombolysis. It's always anticoagulation unless the patient is dying. How do we answer the question to lyse or not to lyse? After you've categorized the patients as being high risk, intermediate highest, other intermediate low risk, it's the high risk patient in whom primary reperfusion is the method of treatment. And if the person is at too high risk of major or intracranial hemorrhage from thrombolysis, then catheter-directed intervention or surgical embolectomy should be undertaken. If the patient is at intermediate highest risk, then anticoagulation is the first line treatment based on the guidelines. And if they crash while receiving anticoagulation, then rescue reperfusion with any of the above three options should be provided. Alternatively, primary reperfusion may be offered, and that's where catheter-directed intervention has become increasingly popular, and the evidence base is still weak. If there are other intermediate risk, PE anticoagulation alone, and low risk anticoagulation that can even be provided at home. So the alternatives to intravenous thrombolysis as a form of primary reperfusion are catheter-directed intervention or surgical embolectomy. And this is a diagrammatic representation of a clot in the left main pulmonary artery before and after catheter intervention. The goal is to break up the clot so that cardiac output can be preserved. Clots may break away and go distally, but at least cardiac output will be preserved and life will be preserved. And here are a couple of devices. You have a rotating pigtail and the other is a thrombectomy device. The latest gadget has been ultrasound-assisted catheter-directed thrombolysis, where these catheters advanced through the IVC into one or both pulmonary arteries and through the clots will allow the fibrin to shake up and loosen, allowing more of the thrombolytic coming out of the droplets in the catheters to penetrate deeper into the clot and break it up. This is something that may take as long as 12 to 24 hours. So you don't really want to consider this as an option in somebody who may die before your eyes. And the embolectomy will remove the clot and take care of the patient and save their life, especially if the risk of intravenous thrombolysis. Let's talk about case 4. 30-year-old asthmatic smoker with ADHD on oral contraceptive pills presents with sudden onset shortness of breath and wheezes. Heart rate's 120, systolic blood pressure 100, room air SpO2 89%. There's pulsus paradoxus, chest displayed auscultation bilaterally with diminished breath sounds, increased expiration, and a faint S1, S2. Chest X-ray shows hyperinflation, ED data CT angio, and it shows a small filling defect in a subsegmental pulmonary artery. What is the next step? A, venous ultrasound of legs, B, VQ scan, C, anticoagulation, D, no anticoagulation.
Guys, if you want to post your answers in the chat, I know you got this. Right, I see them come in. And the majority of people are saying that we should do anticoagulation as the next step, option C.
Okay, so if one were to look at this case, a CT pulmonary angiogram should not have been done in the first place because there's enough here telling us that this patient is presenting with an acute exacerbation of asthma. Nevertheless, the CT angio was done, and such a small filling defect occupying a subsegmental pulmonary artery should not even cause the symptoms that she has. Let's review the anatomy and physiology of the pulmonary circulation. So there's a main pulmonary artery, and there are two branches, right and left, and the right lung being bigger takes the major blood supply 55%, 45% to the left. The right side has 10 segments, so there's 5.5% blood to each, and then there are 20 subsegments. So there's only 2.7% of the blood going into one subsegment. And physiologically speaking, the lungs are the most beautiful organ in the human body. They've got a triple oxygen supply, double blood supply. It's the only organ that receives the entire cardiac output, and it functions as a filter. We walk upright and we're predisposed to DVTs. If one were to take 100 people and do scans on them, a couple of them will have such small incidental PEs. So the guidelines from the American College of Chest Physicians recommend that in a case with what we call isolated subsegmental PE, consider withholding anticoagulation if adequate cardiopulmonary reserve, meaning they don't have bad heart disease, they don't have bad COPD, there's no DVT, there's no persistent risk factor for recurrent VTE, and informed and agrees. And all this is if the risk of bleeding is also going to be high from anticoagulation. So if we go back to this question, there is a subsegmental PE, you're going to lean towards not wanting to treat it. And the next step would be to do a venous ultrasound of the legs to see if they do or do not have a DVT. So in summary, if there's an isolated subsegmental PE, it's usually incidental, doesn't explain the presentation, and you favor not treating if they meet these criteria. Now let's go back to case 2. A 55-year-old man presents with sudden onset shortness of breath 4 days following a sprained ankle that immobilized him. His CT angio confirmed central PE. His biomarkers are normal. There's no DVT. What is the next step in management? A, IV thrombolysis. B, anticoagulation for 3 months. Anticoagulation for 6 months, or anticoagulation indefinitely.
If anyone cares to post in the chat, oh, I see they're coming in. All right. I see at least a couple options, B and C, although probably the majority are saying to anticoagulate for 3 months rather than 6.
Very good. So I'm glad nobody chose IV thrombolysis, which would be an option if a person with PE is dying before your eyes and has hypotension or shock. So let's go over how long should a person be anticoagulated following first episode of PE. And the first question is if the episode was provoked or not. If it was provoked, is the risk factor transient? So going back to this person who sprained their ankle and that immobilized them, it would be a transient risk factor. Yes. And then the next question is the blood clot an isolated subsegmental PE without proximal DVT? No. Then the anticoagulation for 3 months is enough. On the other hand, if the risk factor is not transient, for example, cancer, then anticoagulation would be for 3 or more months. On the other hand, going back up to answering the first question, was the PE provoked? If the answer is no, Then the next question is, what is the risk of recurrence? If the risk of recurrence is low, then anticoagulation should be for 6 months in this case of unprovoked. On the other hand, if the risk of recurrence is high in a case of unprovoked PE, then it should be for more than 6 months. So risk of recurrence, how do we look at determining the risk of recurrence? We'll talk about that. This is reviewing the risk factors for venous thromboembolism that we discussed earlier. Then screening for thrombophilia to determine if that may be a risk factor. One thing for sure, not in the hospital. This is outpatient workup. Second is, if there is a valid reason for testing. One is family history of VT, and family history, first degree relatives. If they're less than 45 years of age, or if there's a DVT in an unusual site, or if it's recurrent VTE, or if there is arterial thrombosis, or if there is warfarin skin necrosis. And the tests are factor V Leiden mutation is checked, prothrombin gene mutation is checked, protein CNS levels, antithrombin 3 level, antiphospholipid antibody levels, and JAK2 mutation is checked. Screening for malignancy in older patients, age appropriate, and in those cases, when age appropriate malignancy does not reveal a cause, then you can use the 8 risk prediction score, which incorporates male gender, elderly age, chronic lung disease, anemia, and thrombocytosis as risks indicative of underlying malignancy. And most common malignancies are usually lung, prostate, colorectal, breast, or uterus. And what you can't find by age appropriate, then you can do dedicated imaging looking for such. Screening for obstructive sleep apnea is also recommended. Risk of DVT or PE is 2 to 3 times higher in patients with OSA than in those without. And OSA is a risk factor for recurrent PE. So if you're trying to decide on whether a patient who has an unprovoked PE should be on anticoagulation, then you look for these possible risk factors because it may not be an unprovoked one after all. When it is truly unprovoked, the risk of recurrence in men is high enough to warrant anticoagulation indefinitely. In women, you should apply the HER-2 score, which is post-thrombotic signs in leg, D-dimer more than 250. You can check it during anticoagulation. Obesity, meaning BMI more than 30, and they're older than 65 years of age. So the HER-2, HER is hyperpigmentation, edema, redness of the leg. And a score of 2 or more means they should continue anticoagulation beyond 6 months because the risk of recurrence in such an unprovoked case is high. Case 5 is a 55-year-old heavy smoker with hypertension and end-stage renal disease who is on hemodialysis, and she presents with sudden onset shortness of breath following recent hospitalization for hyperglycemic hyperosmolar state. Heart rate's 120 beats per minute, systolic blood pressure 100, room air SpO2 95%, chest is clear to auscultation, both legs are swollen, chest x-ray shows a 4-centimeter mass in the right upper lobe, EKG shows some cardia with left ventricular hypertrophy, D-dimer is elevated. What is the next step? A, venous ultrasound of legs, B, DQ scan, C, transthoracic echo, D, transesophageal echo. Obviously, she is a dialysis patient, so you may feel comfortable giving CT with contrast, but that's not an option here. So I'm trying to make a case for where one cannot be given contrast. What would you do?
So the majority are saying that because we can't get a CT contrast, maybe a VQ scan would be the next step here.
Pretty good. So this table here lists the likelihood ratios for confirming or excluding diagnosis of DVT or PE using the various studies available to us. And in a case where a CT angiogram cannot be done because there's a risk of contrast-induced nephropathy that allows us other options to be chosen from. You can do a number of different tests, starting with the pre-test probability, applying the likelihood ratio for the test that you do, and then calculating the post-test probability and going from there. So in a person, yes, Raj asked if someone is already in dialysis, could you theoretically give contrast prior to a dialysis session? Yes, you can give them contrast regardless of prior or after dialysis, which is why I didn't list CT angio as an option here. So a better way of phrasing this question would be if I put down somebody with CKD on dialysis.
Got it. Thank you.
So you can use a test to determine what their post-test probability would be. Remember, the diagnostic accuracy of CT pulmonary angiogram and suspected PE is based on outcome studies, meaning that patients who have a negative CT pulmonary angiogram, the upper limit of risk of DVT or PE 3 months is 2%. So you want to bring the post-test probability of PE down to 2% or less to feel confident in having excluded that possibility. So that's what the goal would be. So you can go to a calculator and input the pre based on Wells clinical model, and then use the test that you want to use and put in the likelihood ratio for that based on the result being positive or negative. And then you get a post-test probability and keep going until you either exclude PE or your probability of PE is reached to more than 50%, which is high enough to justify treatment, even if you haven't really actually seen a clot. Last 60-year-old man with history of X-lap for gunshot wound presents with dyspnea on exertion for 4 weeks. Heart rate 70 beats per minute, blood pressure is 120/80. There's jugular venous distension to earlobe in sitting up position. You hear a bruit below the right scapula. The second heart sound is loud. There's 2+ pre-tibial edema bilaterally. Chest X-ray shows enlarged cardiac silhouette. EKG shows P pulmonale. What is the next step?
Come on, guys. Does anyone else think it's option B? I see 4 responses so far.
Okay, that's very good. So this is a case of chronic PEs, what we call chronic thromboembolic pulmonary hypertension. And what better way than to find out if that's the case than to do a transthoracic echocardiogram? Yes. So CTEPH is rare. Its prevalence is 3.2 per million adults, and only as many as 4% of cases develop it following an acute PE. And after 2 years, the incidence doesn't go up. Associated conditions, in 32% of cases, there is thrombophilia of one or another kind, and 3% of cases have no spleen. So the XLAP for gunshot wound included him having to undergo splenectomy. And spleen is the other filter in the body. So when that's not there, then the lungs bear the brunt of all the debris in the circulation that has to be filtered. And when it fails to use its inherent fibrinolytic system to dissolve clots, then that builds up. So same case, evaluation confirms CTEPH with central clots. Anticoagulation is started. What is the next step? A, catheter-directed thrombolysis. B, pulmonary thromboendarterectomy. C, oral riociguat. D, IVC filter.
I guess this is a tougher question, Dr. Shujaat. It's evenly split. It's
Yes,
either C or D.
I see that this question is beyond what we should expect anyone to answer in the audience. And what this question is covering is the fact that CTEPH is one rare form of pulmonary hypertension, which is virtually curable when such a patient with central clots undergoes surgical pulmonary thromboendarterectomy. Clot is removed, and what is removed looks like this, as opposed to the red clots that are seen in acute PE. Clot is a pulmonary vasoactive medicine that is FDA approved in patients who are not surgical candidates because the disease is peripheral small or who have residual CTEPH. IVC filter will not take care of the problem in the lungs, and catheter-directed thrombolysis is for acute, not chronic clots. And with that, I conclude my talk. Are you happy? I remember to put that down there. Okay, guys, thank you so much for the opportunity to go over this. If you have any questions and there's time, I'll be happy to answer. If there isn't, I'll be happy to respond by email. You may reach out that way.